Of the various forms of thalassemia, our focus today is on Beta Thalassemia Major, like the primary issue at hand. And just to say that among the Beta Thalassemia syndromes, there is a progression of severity from Beta Thalassemia trait in which an individual has a single mutation. And if you have more than one mutation, then it progresses to intermedia and also to Beta Thalassemia Major. And in certain areas of India, E-beta thalassemia is also extraordinarily common. Next slide, please. So babies who have thalassemia are unable to make hemoglobin, and hemoglobin is needed to carry oxygen around in the body. And this figure shows what exactly the defect in thalassemia is. So if you look at the red blood cell, it's a packet that contains hemoglobin, and in the middle is shown the hemoglobin molecule, which has two components. One is the protein part, which is called globin, and then the other is the iron, or the heme part. And in thalassemia, the mutations prevent us from making the protein or the globin, so it's a deficiency of not being able to make globin, so you can't make hemoglobin. And a lot of different mutations, depending upon where you live, can cause this defect. Next slide, please. So it's a worldwide phenomenon, and we are, I think, for today's purpose, we've especially focused on the prevalence in India and in South Asia. And as you can see from this data that was collected along with the World Health Organization, the South Asia is particularly affected by beta thalassemia, as shown in purple. And a lot of those cases are in India. Next slide. When the baby is born with beta thalassemia, they look and feel completely normal at the time of birth. But if somebody would check the hemoglobin, and they would find that the hemoglobin that they're making is only the fetal hemoglobin, and there is no adult hemoglobin. The fetal hemoglobin only lasts for a few months after birth. And if you can't make hemoglobin A or adult hemoglobin, then the blood level drops very quickly. So the parents, if they'd been tested, would have, both of them would have beta thalassemia trait, but they wouldn't have any abnormalities and they would feel well. And if we did DNA testing on the baby, we would find 2 beta thalassemia mutations. And the right side shows on the top is normal blood, which has a lot of red blood cells. And on the bottom is a baby with Beta Thalassemia Major. They can only make a few red cells, very little red component of the red color. Next slide. So as the fetal hemoglobin goes away, within a few months, the baby becomes severely anemic. They can't feed very well. They're sweating all the time. They look very pale and tired. And if no treatment is given, a number of different complications are going to develop. They won't be able to gain weight, repeated infections, and heart failure develops, and an untreated patient would die within 1 to 2 years of birth. Next slide. So the treatment is to replace blood. So if you can't make blood, you have to give blood transfusions. And because this is a genetic disease, it's not going to go away. So the transfusions have to be done throughout life. So typically, once a month, transfusions have to be given. And for transfusions to be successful, you need a lot of infrastructure so that the blood is safe. And then you can manage any complications that develop from the transfusions. And the treatment has to be uninterrupted, because if you give blood at some points and it's not available at other times, the health of the baby will continue to deteriorate. Next slide. The blood transfusions come with a lot of risks of their own. So blood safety is very big in managing patients with thalassemia. And the one big problem is the written on the right side, which is that blood contains a lot of iron. So if we keep giving blood transfusions, the iron is going to accumulate in the body. That's called iron overload. Next slide. So here are two pictures. There's one on the left side is a child who has never been transfused very well due to either lack of blood, but at that time, in the 1960s, we also didn't know how to manage thalassemia very well. So they develop all these bone deformities that we typically associate with thalassemia. But in the modern time, with better availability of blood and better understanding of the disease, patients don't have to look that way at all. They can look and feel completely normal, as shown on the right side. Next slide. But the repeated blood transfusions bring in iron, and iron continues to accumulate in the body, and it can cause a number of different complications. So even though you can avoid the problems from low blood or from anemia, there are the complications progressively of iron overload over the first 15 to 20 years of life. So if it goes into the heart can fail. If it goes into the hormone organs, then a number of different hormone deficiencies, including diabetes, can develop. You can get liver damage, and all of these can lead to organ failure and death within first 10 to 20 years of life. Next slide. This shows the accumulation of iron in the liver tissue. If you did a biopsy, all the blue, dark blue areas, and on the heart, muscle on the right side, it shows how iron can accumulate and cause damage to the organs. Next slide. So to be able to manage iron, we have to measure it so we can control it. And that's now done using MRI. And you can see the iron gives a dark color to the liver and the spleen and the pancreas, as shown in the picture. And that's how we can measure iron. But access to good MRI scanners is really important. Next slide. And once we know that there's iron, then the treatment is regular chelation therapy. And that's using medicines that will bind to iron in the body and help it to get out of the body. So these chelation medicines have to be available and given every single day throughout life, along with blood transfusions. If you're able to manage these two things very well, then we can control the iron and provide what we call comprehensive care for thalassemia, in which multiple different specialties get together to look after the patient. And these patients can live a normal, productive life and can have family and can live up until 60s, 70s, like a normal lifespan. But the overall care is very intensive and has to be organized, and these may not be available everywhere. Next slide. So because of the nature of the treatment, alternative therapies have been developed for thalassemia. Next slide. So the first one being bone marrow transplantation. Here, bone marrow that can make blood, typically from a brother or sister, can be transferred into the patient. This works very well if you have a match, a bone marrow match within the family. But if you don't have a match, then the risks are higher. And that includes becoming seriously ill during the transplant and including death. So even though bone marrow transplant has been with us for almost 30 years, we needed new methods to treat thalassemia. Next slide. And that is now gene therapy for thalassemia. So this has been a tremendous advance in our field. Last year, the first gene therapy for beta thalassemia was approved for use in the United States. Next slide, please. And The main difference here is that you don't need a bone marrow from a donor. You can just take the bone marrow from the patient, as shown on the left side, and use the bone marrow cells to introduce a healthy gene into the cells, and then these cells are returned to the patient and they can start making hemoglobin, which the patient couldn't do beforehand. And that's shown on the right side. The new red cells that are formed are the consequence of introducing a new gene into the cells, into the stem cells. Next slide, please. So with all of this and the requirement of intensive management of patients, the cost of treatment is extraordinarily high. Prevention of thalassemia has assumed greater and greater importance. The many areas of the world, including some Mediterranean countries, especially Cyprus and other parts of the world, have shown a remarkable success of education, screening, and genetic counseling. And in many countries, the birth of thalassemia babies have become very rare. Next slide. The situation, as far as we know in India, this is data from over 10 years ago. Maybe 1 in 20 or 1 in 25 people overall are actually carriers for thalassemia. So the likelihood that two carriers will have a baby together, will marry and have a baby together is fairly significant. So at least 10,000 babies are born with Beta Thalassemia Major in India every year. And as the lifespan of these patients has improved with treatment, we have more and more patients, and now probably the total number of patients exceeds 100,000 and could be a lot higher than that. So it has become a real priority that we also, as we are making advances in the treatment, that we also look at better methods to prevent new births with thalassemia. Thank you very much.
That was fantastic. Within the time that we have today, it was a great introduction. Thank you for that.